All right, let's talk about the Polytrauma viva. This isn't just a test of what you know, it's really a test of how you lead under some serious pressure. The examiner wants to see a consultant in the making. So, what we're going to do is build a rock-solid framework that's going to help you deliver a safe, structured, and really high-scoring answer every single time.
So here's how we're going to break it down. We'll start with the definition, then walk through the ATLS survey, cover resuscitation, surgical strategy, back it up with evidence, and then the important part, how to actually win the viva. Think of this as the skeleton for your entire answer.
Okay, section 1, defining your patient. When that viva kicks off, your opening line is absolutely critical. An average candidate might give a kind of vague definition, but a great candidate, they start with precision. This is your first shot to really impress them with a modern, evidence-based approach.
Your opening line should be quoting the Berlin definition. Just saying that immediately signals that you're current. It's such a powerful definition because it combines two things: the anatomical injury, that's the Injury Severity Score, or ISS, with the patient's actual physiological response. So when you mention specifics, like a GCS of 8 or less, or a significant acidosis, you're showing a much, much deeper understanding than someone who just quotes an ISS score alone.
So, why all the urgency? Well, the trimodal distribution of death explains it perfectly. That first peak, the one that happens in seconds, that's often non-survivable. The third peak, which is days or weeks later, is all about managing complications like sepsis. Our focus, the entire reason ATLS exists, is that second peak. It's the golden hour where what we do can literally change the outcome. And that brings us right to the practical stuff. To prove you're a safe surgeon, the examiner needs to see a systematic, repeatable process. And that process is, of course, the ATL's primary survey. It's your mantra, life over limb, every single time.
You have got to be able to recite the ABCDEs smoothly and with confidence. This is completely non-negotiable. It's airway with C-spine control, breathing and ventilation, circulation with hemorrhage control, disability using the GCS, and exposure while making sure to prevent hypothermia. And the crucial part, you have to state that it's sequential. You assess and treat threats in this order before you even think about moving on. This is the bedrock of safe trauma care.
Now, that C for circulation leads us right here. This is the point where the patient is actively dying, and you have to take control of the chaos. This section is all about stopping the bleed and reversing the shock, and you do that by activating a team-based, protocol-driven response. And this is your response. The key phrase you need to say is, I would activate the major hemorrhage pathway. As you can see from a flowchart like this is not a one-person show. It is a pre-planned multidisciplinary process. By activating it, you're not just being a surgeon, you're being the leader of a system designed to work under extreme pressure, coordinating everyone from ED and anesthesias to hematology and the surgical team.
So what does activating it actually involve? You've got to be specific. A really great modern trigger to mention is the ABC after 3 rule. After you've given 3 units of red cells, you formally stop and reassess if you need the full protocol. You must mention giving tranexamic acid early and quote the CRASH 2 trial. And you have to emphasize correcting the lethal triad, aggressively warming the patient and aiming for that balanced 1-1-1 resuscitation with packed cells, FFP, and platelets.
And hey, to show you're really on top of recent advances, you can briefly mention REBOA. Just saying, for a non-compressible torso hemorrhage, I'd consider REBOA, shows you're thinking about cutting-edge techniques. REBOA, that's resuscitative endovascular balloon occlusion of the aorta, is a key temporizing measure. It's basically an endovascular balloon that buys you critical time by controlling the bleeding from the inside. Okay, so you've stabilized the patient. Now comes the core orthopedic decision. What is the right surgery at the right time for this specific patient? This is the classic viva debate, and you need to be able to clearly articulate the difference between DCO and EAC. To really get this, you got to look at the history. Back in the 80s, the philosophy was early total care. Just fix everything right away. The problem was, this led to what we call the second hit phenomenon, where the trauma of the surgery itself pushed already unstable patients into ARDS and multi-organ failure. And that's what led to damage control orthopedics in the 2000s, a strategy of less is more for the absolute sickest patients. So the modern approach is all about finding that right balance. DCO is for the patient who is still physiologically unstable. They are truly too sick to operate. The goal there is quick temporary stabilization. Think things like applying a pelvic binder or throwing on an external fixator.
But for most patients who actually respond to resuscitation, the modern standard is early appropriate care, and here the philosophy is totally different. You resuscitate them in order to operate, with the goal of getting to definitive fixation within 36 hours.
So how do you decide which path to take? Well, it's not a guess. It's all about the data. If you're going to proceed with early appropriate care, you have to be able to state these targets. You're looking for a lactate below 4, a pH above 7.25, and a base excess better than -5.5. These are your physiological green lights for going ahead with definitive surgery.
All right, let's justify the plan. Look, any candidate can outline a management strategy. A high-scoring candidate justifies every step with landmark evidence. Quoting the right papers shows the depth of knowledge that the examiners are really looking for.
When you talk about damage control orthopedics, you should mention the work by Pape. This foundational paper from 2002 is what gave us the evidence for DCO. It showed that it was a valid way to avoid that second hit in high-risk patients. You don't have to recite the whole paper. Just a simple mention, based on the work by Pape and others, is a really powerful statement.
So here's the evidence boiled down into 3 essentials for your viva. First, for TXA, you quote crash 2. Second, when you're talking about stratifying patients, you can reference Pepe and Janudis's classification of stable, borderline, or unstable. And third, for your resuscitation strategy, you justify that 1:1:1 ratio because it's proven to achieve hemostasis and reduce mortality. Simple as that.
And now for the final section. We've built the knowledge base, so let's talk about performance. This is all about packaging your knowledge effectively, avoiding common traps, and using the kind of language that signals seniority and, most importantly, safety.
You can really see the difference here between just passing and truly excelling. A common pitfall is being too rigid. Instead, you need to show you can adapt your plan on the fly. Don't ever mention a classification unless you know it inside and out. It's much safer to stick to core principles. And always, always circle back to the fundamentals. State clearly that you are actively managing the lethal triad.
These are the phrases you want to sprinkle throughout your answer. Think of them as signposts. They show the examiner you get the key concepts and that you can speak their language. Using terms like second hit phenomenon, lethal triad, and the philosophy of resuscitate to operate gives your answer structure and proves you have a high level of understanding. This quote really captures the whole spirit of early appropriate care. The key thing to get across is that this is not a blind rush to the operating theater. It's a dynamic process that demands constant communication with your anesthetist. Actually saying out loud that you would stop if the patient's physiology deteriorates, like if their lactate starts to climb, is the hallmark of a mature, safe surgeon. And finally, here's where it all comes together. The examiner hits you with this. You're 2 hours into a femoral nailing. The anesthetist tells you the patient's lactate is now 4.5 and it's rising. What do you do? I mean, they're testing everything here. The second hit, your response to data, your communication, your commitment to safety over the procedure. Take a breath. Structure your answer. What do you do? And just as important, what do you say? Your answer to this very question shows them if you are truly ready.